All right, today we have our friends from Hennepin County Medical Center. They're going to be talking about their Heals on Wheels and how to engage community in an integrative pain care. And this is really an amazing project that they had grant funding for. So excited to kind of have them talk a little bit about. St. Cloud is going to be one of these places. So we're pretty excited about that. Next slide. So moving on to the announcements, we have a lot of interesting talks coming up. Actually, we just got Cole Perringer to talk in February, and interestingly, he's going to be coming on about xylazine, something we've been looking forward to for a while. He's got a great talk. But next week, recovery capital assets, not abstinence. And so that should be a great talk, but lots of good things coming up. Catherine comes back again, even in just a few more weeks. So she's kind of the big hitter here lately. Next slide. All right, remember there's free CME. Please make sure that when Katie sends you that little email that you fill that out. It's just all free and fun to get. And remember, we do love it when people have on their videos. It's so much more fun if they can talk to your face and not the black box of COVID. So next slide. Remember, if you have any questions, please call us. We get lots of fun calls from all over the state about different little issues. And if we don't know the answer, we usually call Hennepin, actually. But if we don't know the answer, we call somebody and we find out how to help you. So please feel free to reach out, myself or Aaron. And remember, you can go to the website as well. You know, one of the things people have been asking about lately is these macro dosing for Suboxone. I'll tell you, there's not one on there. There's not a protocol, and that's very complicated. But if you have questions about that, easier to call Aaron and kind of get that figured out. Next slide. So we will let them share their slides, and if you each want to kind of introduce yourself and tell the group what you do for a living, that'd be great.
I think I might
Wonderful.
share my screen.
So Catherine is going to share her screen.
Yeah, I think the host disabled participant screen sharing. I think I need to be like dubbed.
Oh, here, let me fix that. Sorry.
Okay.
Okay, there you go.
There, can you see this okay? All right, great.
Okay, well, thank you, everyone. Thank you for inviting us. It is such a pleasure to be back into ECHO again, into ECHO presentation. We are all going to take turns. We are going to introduce ourselves and we are going to take turns presenting. So while you take a look at our pretty pictures, I'm going to start with my introduction, and then I want to provide a larger context for this work before our individual team members take the presentation over. So my name is Aarti Prasad. I hold the administrative title of Chief Strategic Development Officer at Hennepin Healthcare, but I specifically said that's my admin title. But actually, I'm a primary care physician. I'm a general internist, and my passion is for holistic and integrative medicine and whole person health. And I've been involved in this work over 2 decades. I came from University of New Mexico, where Project ECHO originated, actually was born. And we just had 20-year anniversary of Project ECHO. And Kurt and I were there in Albuquerque celebrating that with the ECHO team. And coming to Minnesota 6 years ago, as the department chair of medicine at Hennepin Healthcare, we kind of planted a seed of ECHO in Minnesota too. So now we have all these wonderful programs going through ECHO. The larger context for this work that we are going to present today is actually related to opioid crisis. This is why all of you are here on this platform. So we knew about opioid crisis. We knew about the opioid dosing, overdosing, and deaths related to opioid, but we never named it opioid epidemic until like 5 or 6 years ago. And this really became a big deal. And a lot of programs started nationally, locally, regionally. And one of the things that also started parallel to the work slightly related to direct patient care or secondary prevention of opioid is also the work in non-pharmacological pain management, because the pain pills started, some of this crisis work, or majority of it. There are other products too, which are related to crisis. So at that time, American College of Physicians, the Joint Commission, and also CDC came up with the recommendations, national recommendations in non-pharmacological pain management. And a group that we belong to, which is called the Consortium of Academic Health Centers for Integrative Medicine, which has membership of about 150 or 170 academic health centers who have programs in integrative medicine or integrative health, clinical education, and research. They came together and they created a pain task force. And this pain task force worked with NIH, National Center for Complementary and Integrative Health, to draft a white paper on integrative pain care. And that white paper is kind of the seminal paper for our colleagues in integrative medicine. So that work was happening. This paper was getting published. We were dealing with opioid crisis in the country. And what was happening in Minnesota at that time, that the state was working on this penny for the pill, act, and trying to get funding from the pharmaceuticals, from the drug companies, and Governor Walz actually created this ORAC organization, a committee, which would actually distribute the funds through granting process. And we are funded through ORAC, and we are going to hear about it a little bit later. But I want to give credit to some people who are not on this slide. You don't see them, but they were working in the background to create a funding stream for integrative pain care. And one person that I really want to call out is Suzanne Koplinger. Suzanne Koplinger was the director of a local foundation called the Catalyst Foundation, which is not in existence anymore. And she reached out to us and she did advocacy work at the state level for integrative pain care. So when the first funding of opioid bill came through, which was $8 million in 2019, and Kurt and his program was also funded through that, 1.25 million was assigned to integrative pain care. And at that time, Hennepin Healthcare applied for grants through MDH because the money was flowing through MDH. And we applied for a couple of grants, a demonstration project and a mapping study that we'll talk about a little bit later. But this is the background. I wanted to provide you the context that we are now working together in upstream, midstream, and downstream work that you are going to hear about. But we are very grateful to some of these people who did the advocacy work. We are grateful to the state, and we are grateful to all of you who are actually participating in Project ECHO so that we can make a difference in the community. So my colleagues here are, I'm just going to name them, and then they are going to come on and introduce themselves. Dr. Sue Hadow, Dr. Kate Shafto, who couldn't be here because of family reasons, and Catherine Justice. Thank you.
I'll take the floor next. I'm Sue Hadow, family physician working through Hennepin Healthcare for the last 12 years. I've been a family doc for 34 years now, and I'm board certified in family medicine. I'm certified in integrative, holistic, and functional medicine as well. I've seen the opioid situation develop from my days as a med student, and when we hardly use things as a resident, to I'd tell that minimal use to maximal use, and now to us really trying to work on right sizing use. And I have, for the past 6 to 7 years or so, been running integrative pain groups in our family medicine clinic at Whittier, and really working on the non-pharmacologic approaches to pain care. And I've had some great experiences in doing so. And I hand you the baton, Catherine.
So I'm Catherine Justice. I'm a doctor of physical therapy, integrative physical therapist, and a yoga therapist, and I'm the program manager for integrative health at Hennepin. And so I've been the one managing the Heels on Wheels program.
Okay. So today's learning objectives are to understand evidence-based integrative health approaches to chronic pain as up, mid, downstream interventions for addiction prevention and treatment. And we will explore innovative ways, such as Heels on Wheels, to take integrative pain care directly to historically under-resourced communities to strengthen our community connections, and to recognize the value of group medical visits as an effective tool for people who experience chronic pain living in under-resourced communities.
And so one of the first things we'd like to do is to take a moment right now and to do one of the things that we do in every one of our groups, whether it's in community outreach, in our appetizers, or in our full meals. This takes about 2 minutes or so. So this is called quick coherence from HeartMath. I don't know if anyone's heard of this or not, but coherence, this practice has been shown to bring us into a state of optimal learning, connection, and helps to balance our sympathetic and parasympathetic nervous systems. So please find yourself in as comfortable a position as you're able in whatever setting you're in. Notice the support of the chair or the object you're sitting on. And I invite you to allow your gaze to soften, or if you feel you can where you are, allow your eyes to close. You may notice that your breath is already slowing some and deepening some. Now bring your attention to your heart center. Imagine your breath moving in and out through your heart center. Just easy. The in-breath balanced with the out-breath in length. And now, I invite you to activate a regenerative emotion or feeling, such as appreciation, love, or care for a person, place, pet, or thing, or a feeling of wonder, awe, calm or ease, some feeling that makes you feel good. And as you make a sincere attempt to call up that experience and feel it in your body, keep this feeling going while you're breathing in and out through your heart center. Continue to experience that positive emotion while breathing in and out at your own pace through your heart center. And now, allow your focus to return to the support of your chair and your feet on the ground. And gently bring your awareness back to the room and allow your eyes to open if they were closed, and welcome back. So what is integrative pain care anyways? This is a very busy thing here, but I'm going to draw your attention to the middle of the circles. The Alliance to Advance Comprehensive Integrative Pain Management has graciously created this lovely graphic that we find very useful. And what I want to focus on is the center here under individual goals, the person. At its heart, integrative pain care is patient-focused and centered. And patients taking into account their social factors, biological factors, psychological and spiritual factors, and the environments within which they live. And as we then do that, we ask patients, what matters to you? Compared with the question of what's the matter with you? And that shifts the narrative and it shifts the conversation. And then in an integrative process, we go through really a lot of the things on this circle to figure out what works best for this patient, their values, their moment in time, their community, their resources. And it may be lots of conventional care. It may be mostly behavioral health. It could be the complementary and integrative or digital technologies and any combination thereof. And, you might be looking at that going, well, yeah, there's all these great things out here and I have access to about 4 of them. Or I know about a couple of them. So what do I do about that? I'm going to shift it to Dr. Prasad to tell you a little bit about what you might do as you see this other graphic next to the circle called No Pain Minnesota.
Thank you, Sue. So as I pointed out, with this original funding of $1.25 million, the original grants in 2019 through MDH, there was one large grant, which was called the Mapping Study of the state of Minnesota, and a demonstration project. They gave funding for 5 demonstration projects. And we were privileged to have the 2 grants, the one larger grant, which was the No Pain Minnesota. We called it No Pain Minnesota, which stands for Non-Opioid Pain Elevation Information Network of Minnesota. If you have your phones, you can scan this QR code and it will take you directly to the No Pain Minnesota website. This is the work of love for our team that we have done for 2 years. And Minnesota is now the first state in the country to have mapped out the non-pharmacological pain management evidence-based resources for integrative pain care. So this website, patients, providers, administrators, anyone can do searches within certain miles of their vicinity, and they can find integrative pain providers. And we have provided research for all of these modalities, as well as references for each of these modalities. So you can play around and you can actually share with others. You can share with your patients, you can share with your colleagues, you can share with your hospital administrators. This is available. Clearly, ongoing work is needed to maintain the website. So we are working on additional funding to continue to maintain this website. But this is a great resource. And when we were working on this, starting in 2019, the concept of Heels and Wheels was coming to us because we felt that, well, we have identified these resources, but we see there are certain parts of the state where these resources are not available. And not everybody has transportation to go to these services, because as part of this study, we did one-on-one surveys. We surveyed about 49 stakeholders who were patients, who were providers, who were health system administrators, who were insurance administrators, and we learned a lot, and we are about to publish that paper. Our first paper just got published, actually. It is online on No Pain Minnesota. It's in open access in Journal of Complementary and Integrative Medicine. And our second paper about the qualitative studies about it published. But we learned through that process that how these things are coming together. We are learning about the barriers and facilitators to this type of care. And we know the areas where people don't have access. We know about the diversity of our patients and patient population and the communities that we serve. And how do we make these services available to them? And we started to think about this Heels on Wheels model. And when ORAC, which stands for, which I didn't say, Opioid Epidemic Response Advisory Council, somehow, somewhere, they actually heard this. They came up with their own concept that as part of opioid epidemic, we need to focus on prevention of opioid crisis. And they put out some RFPs, and one of them was for holistic access to holistic pain management. And we said, aha, this is our opportunity. If we can provide access to patients, how about we take access to them? And that's when the concept really got materialized, the Heels on Wheels.
I just wanted to give like a momentary pause with a shout out to a couple of echoes that are going to be coming this April. One of them specifically on integrative pain care. So if anything in this presentation is sparking your interest and you want to do a deeper dive, you can register. Well, at the end, I'll give you some links of how to register and get some more information, both on one on integrative pain care and another that will be starting on trauma-informed care, which kind of go hand in hand together. It's hard to have integrative pain care if you don't have a trauma-informed approach.
So we're talking about pain, right? And we know pain happens. You're not going to be able to avoid it in your life. And what we want to do is prevent acute pain from becoming chronic pain, because this is where we see so many of our problems with opioid use disorder coming in. And so We don't understand all the risks for chronic pain, but we do actually have some ideas of what are some of the risk factors and protective factors that have been outlined to suggest these are at higher risk for acute pain to become chronic pain. And curiously, none of these things are medical interventions, just to call your attention to that. I find that really fascinating. And that recognizing that this potential is there, we can keep a broad base of inquiry when we're helping patients manage their experience with chronic pain, reflecting back to that circle, what are all the things that are influencing this person's pain experience? And let's keep these ideas of risk and protective factors that you can see. Some are external, like environment, chaotic environment, or having a lot of social supports. And then there are internal triggers, like someone who just gets really bad sleep is at an increased risk for developing chronic pain if they've had an acute pain event, or if they're feeling kind of burned out or lost or without purpose in their life. So looking at these dimensions can really help inform us as we move forward into our integrative pain care approach. And as we talk on the next slide about upstream, midstream, and downstream considerations of where integrative pain care fits through that lens of the opioid use disorder.
So thinking of integrative pain care and how it can be a tool for both for all up, mid, and downstream opioid use disorder care and prevention. Sometimes I think of it as like if a person never experienced chronic pain, if we could intervene sooner before acute becomes chronic, that's upstream. We prevented them ever being needed to be prescribed an opioid. If we provide early education and support on how pain and stress and trauma all interfere in our bodies, again, that will help us prevent acute pain from becoming chronic. If we look at how opioids are being prescribed and we actually follow the prescription guidelines, people won't be prescribed opioids for chronic pain, and then we won't have issues. So again, these are all some upstream ways. But in order, if they come to their doctor with pain and their doctor is following the guidelines and says, this isn't appropriate to give you an opioid, but I don't have any good alternatives for you, that's not going to work for the patient either. So all of this advocacy work with the mapping and other things that have been done throughout the state of Minnesota to increase access to integrative pain care, to actually evidence-based tools and resources and services that people can access for their pain management. Again, that's all upstream. And then I think of midstream as someone who has experienced pain and may or may not have been given an opioid for that pain, but they don't have a full opioid use disorder. So this work, integrative pain care, fits into that in that it becomes the point of service. So this is the moment when someone is experiencing pain, maybe it's getting into that chronic zone where the physician or provider, whoever it is able to provide these evidence-based alternatives. And looking again at what Sue was talking about in that last slide about how many of the factors that influence whether acute pain becomes chronic or what makes pain persist, that so many of those factors are whole person factors. They're the psychological, they are the emotional, they're the environmental, all of these things that are complicated and many factors, including social determinants of health as being one of the major factors, again, that can lead towards pain persisting. And then we might even find people downstream. So maybe they have and are experiencing chronic pain and perhaps also opioid use disorder. So then when we are able to reach these people, then we can offer them some of these alternatives to opioids. And theoretically throughout this model, that patient could then start to reduce or taper off their opioids because they would have viable alternatives that work for them. And that's where Heels on Wheels came in, was this idea that maybe we could find kind of all of these up, mid, and downstream into one program. So we were generously funded by the Department of Human Services as part of the Opioid Epidemic Response Advisory Council, as part of OREC, under this Access to Holistic Pain Management category. And the Heels on Wheels program started with a lot of food metaphors because of the name. And this is, you can see my background in theater that I like to, I always look for the story. So we conceived of this program as having appetizers, a kitchen, and a full meal. So, and I'll talk in a little bit more depth as to what each of those are. But really this came from what we saw as this deep need in the state of Minnesota to address the opioid epidemic from this perspective of integrative pain care. So the appetizers are short little workshops that we do in the community. So we bring the care directly to people. And these appetizers are done in a variety of community settings. And to decide where we were going to put our resources and go, the initial Heels on Wheels funding was for Hennepin County. So we were staying in that geographical location. But I worked with the equity team at Hennepin to help decide where in Hennepin County were we going to go. And we looked at a variety of things of both underserved geographical areas, as well as specific populations that historically either have suffered more under the opioid epidemic, particularly Black and Indigenous Minnesotans, and then also other communities that were historically underserved by the medical community in general. And so through kind of creating a grid between like, here's geography and here's these specific populations, we kind of mapped out on that grid the different locations where we went. So it ended up being homeless shelters and low-income senior housing, HIV positive housing. We went to some farmers markets. It was a real variety. And it was a team that would go to these places. So it was usually myself and either Dr. Haddow or Dr. Shafto or Dr. Prasad. And an acupuncturist came with us. Sometimes we had students from Northwestern Health Science and massage therapy and acupuncture students. And Pathways Minneapolis would also provide us with some massage therapy volunteers to help with these. But really the star of the show at the appetizers was our community ambassador, who is this woman, Joanne Bell was her name. And she came with us to offer up her lived experience of what it was like to go through one of these group visits for her chronic pain. And she was gracious enough to record a video for us. And I don't know if we have time for the whole thing, but I'm going to play a little bit of it now for you.
I'm Joanne Bell, and my experience with the book movement that initiated in October, nearly 2 years ago, and the experience was absolutely more than what I expected. It became really good for me because the information that they brought to the meeting was really valuable and really needed for that time that we were there.
Catherine, that's really hard to understand. I don't know if you can hear, but we can't.
Okay, let me see. I might need to do that, like the share audio.
I think we need to share audio.
Yeah, let me find
Yeah,
that.
that sounds bad.
Thank you for letting
Sorry,
me.
everybody. Thank you for being patient.
I'm looking for share sound. Here we go. Let me try this again.
Initiated in October,
Is it better? Okay. Thank you.
2 years ago in October, and it was for 8 weeks. And the experience was absolutely more than what I expected. It became a lifeline for me because the information that they brought to the meetings was so valuable and so needed in that time that we were there. They brought in physical therapists, acupunctures, therapy, and other therapy. And we talked about our minds, body, and soul, how to heal without taking medication, hard medications. And in the process of doing that 8-week class, I found myself decreasing in my medication. My body was feeling better. Just my overall experience made me a much better person when I left out of the class. And
So I'm just giving you a little taste because I know we're low on time, but Joanne was always the star of the show, sharing her experiences, and she was just a really important member of our team. We also brought along to these appetizers little self-care kits, which you can see an example of up in the corner, where people got some hot cold packs and acupuncture seeds and a gift card to healthy food and a whole packet of information and resources. And the kitchen, which isn't listed on here, but the kitchen was really our internal work of where we cooked up the infrastructure to support this program. But I will let Sue now talk a little bit more about the full meal, which was our group medical visit.
So yeah, once we got our work done in the kitchen and we'd been out in the appetizers soliciting people to come for a full meal. And we presented full meals. There were 3 different cohorts, 8 weeks each session, like Joanne had suggested. And we focused one session on headaches, one on muscle and joint pain, and one on emotions and pain. And each of the sessions contained these different things you can see under the session elements. I won't read them out to you. You can read them yourself. They're easily enough. And for me, this is where the fun and the magic really happens. People got together. Anyways, we'll go into more of that in a second, but we were co-facilitated, Catherine, the integrative PT, and either one of the physicians. And then in our psychologic one, we had our psychologist who's not particularly integrative, but is really interested in pain management. It's one of the things she actually did her PhD on. And then we had some guests who did acupuncture, chiropractic, psychology, sleep medicine, spiritual care. We even had a Reiki person come in sometimes and do some energy healing. We initially have people go through guidelines of being on a group and what that means and how do we behave in a group, and confidentiality. This was our first cohort, and we're in the 2/3 of the way through our second cohort now. So our next one's coming up soon. And I will say that it's nice to have 2 facilitators in the group. That is super helpful. And let's see, whoops. We work, so this is how our topics are for each of the cohorts, head, heart, and body. And we weave the mindfulness throughout. And we work from this premise that knowledge is power. And you heard Joanne say, we needed this information. And that shared experience that we do in the groups promotes this potential for compassionate change, regardless of socioeconomic or educational status. And so to that end, we go through each of these different topics. Each week has a different topic and experiential aspects. And this shows you all the different didactics we do. And we do them all through that lens of chronic pain. And we provide opportunity for gentle movement with Qigong or yoga and mindfulness activities like body scan meditation or mindful eating. And they witness commitment. That's the other magical part, is the group witnesses things together and they support one another. And they say, oh, were you able to do that? Sort of thing. And, all right, I got to share this one because, all right, yeah, keep going. And then that's all right. This is the nuts and bolts. The grant paid for a lot of things, including the co-facilitators and the guests and the gifts and that sort of thing. And the physicians, we build like a regular 99213 or 99214, depending on the visit itself. So I build for my time in those groups. We did these forms. I think if we go back, we had the pre-visit forms and the post-visit forms. And the groups were mainly either predominantly through Medicare and Medicaid. So nicely, the participants rarely ever had a copay as well. So that was very helpful. And yes, they are covered. So we had about 28 participants in the first go around, 75% attendance. And I'm just going to hit a couple of highlights. We had those pre and post weekly sheets that they filled out, one before the visit and then after the visit, and then the Promise 29, which we did at the first group, the fourth, and then the last group. Some brief data from that is the average pain score from the beginning of a session to the end of a session went down by a factor of 2.2. And that is out of a 10-point scale. So in real time, people experienced a decrease in their pain while they were in this group. And to me, that was sort of magical and inspiring. And I would talk with people, and I still do, about saying that these practices are like taking a dose of medication. And they sometimes last even longer than your ibuprofen or your oxycodone will last. They can, and you can do them anytime, and you don't need a prescription, and there are no bad side effects. So I put it into a framework where people really get what we're talking about. The Promise 29 showed that there were reductions in anxiety and fatigue and an increase in social participation. And social participation is one of the things that people often say that they miss in their, what is this pain making it hard for you to do in your life? So to find that social participation increased is really a positive outcome for us. We also had a question of what portion of the group visit did you like the most? And invariably sharing with the others was the most common response. And then followed by information about learning about my nervous system, nutrition information, and learning meditation skills. And everybody consistently reported experiencing relaxation during the groups. Next slide. So we use this whole person approach, and we use the group model visit to fill in where one-to-one visits fall short. And that is, we get time to talk about the depth of nutrition, of exercise, go into the evidence, educate on recommendations, answer questions in depth. The groups usually run about 2 hours with a break in between. So we have some time to really get in there and do some stuff. And they share their experiences. I'll tell you, I don't know how many times I've told people, decrease your refined sugar intake and you're going to have less pain because your inflammation will come down. It'll come down. They're like, But when Dee says to the group, I really went and stopped taking this sugar. I said, what is this going to give me? I think this sugar is not good this time. So I didn't do it. And I tell you, I had less pain all week from not doing that. The group lights up and looks at her and says, oh, okay. I think I might be able to try that. So we facilitate those kinds of insights and capacity. And it also allows for the human connection, which reduces social isolation. And we all know now that social isolation is a risk factor for heart disease. So this is powerful medicine. And we really want to nourish that experience of the power of a small change. And so that you don't have to change your whole lifestyle to make a difference. Mm-hmm. One small change can have powerful downstream effects. So, and then the group really is instrumental in relieving loneliness and provides this empathic group to be accountable with and for. And if I had a nickel for every time that a participant said, it's really helpful to be around others who get me, I'd have a lot more nickels, but maybe I should ask more for quarters or dollars. It may also be helpful for the group visit to help us in achieving our quintuple aim with improving patient outcomes, improving patient satisfaction, improving provider satisfaction. It's a great antidote to burnout. So you're not saying the same thing over and over and over and over and over multiple times a day. You get to say it in depth once to a group of 8 or 9 or 12 people, and it's so powerful. And provider satisfaction improved, better health equity. We actually, in the grant, were able to provide rides for people so that people who struggled with transportation could come to the groups. And we don't know about the decreased cost. We would like that to be a factor, but we haven't been able to analyze that data. Thank you. Next slide.
Hi, everyone. So I'm back again to tell you about how we are taking how to our larger communities of Minnesota. So again, we are privileged that we got another grant from ORAC, and we think, we are doing all this great work. Our team is really amazing. You're hearing from some amazing people today, and they are so dedicated to this work and working with our underprivileged, population of patients. And we said, we want to share our wisdom. We want to share with others in Minnesota how to actually help them and how to help their communities, and really expand the work of this holistic access to pain and taking access to the communities we serve. So we applied for another grant that is being awarded to us, a generous grant, Center for Teaching, Learning, and Coordination Wellness on Wheels. It is called TLC WOW, from how we are going to WOW. And we will be training other health systems in the HOW model. And we have the funding to support maybe 1 or 2 additional sites. So if you're interested being part of the HOW and WOW community, we have funding to support this work and mentor and guide you in this work. Would you like to be one of our house sites? As I said, recruiting for 1, but we could actually maybe have 2 sites. And Catherine has already put the plug in for our integrative pain care echo for a deeper dive into these things. As you know, we are touching these topic areas with patients, but we want to take a deeper dive with providers. So you all can be doing this work. This is how we build our community. This is how, we build our wisdom, combined wisdom. It's a collective. It's not our work. So if you are interested, please send an email to Catherine, and Catherine has some Google Forms I think she created that people can fill out. So we would love to have you connect with us through various ways.
Yeah, I just threw in the chat my email, which you can reach out about any of these programs. And if you're in particular interested in the integrative pain care or the trauma-informed care echoes, there's some sign-up forms there as well. And now we're pretty much just open for questions or thoughts that people have about the Heels on Wheels program or integrative pain care, or, what our favorite animals are, whatever you want to know. We're here for it.
I was pretty sure it was cats, but it's with Catherine. If people have questions, just feel free to unmute and just butt in. I have a number here that I was going to kind of start with. Anybody want to start before me at all? Or you can chat them in. We're happy to take them that way as well. My first question is, often when you see people who have chronic pain, they're trying a lot of things that might be over the counter or marijuana or all these other things. How do you kind of deal with that when, for instance, when I see patients in the addiction clinic who are having certain issues and they're still smoking marijuana, that disrupts sleep. That makes people irritable. That can make them anxious. And so do you address those kinds of things as well?
I'll approach that a little bit. I definitely address alcohol, stimulant use, and marijuana use. And that's not, at least in a medical cannabis context.
Yeah.
We talk about it, and I don't necessarily say I won't care for you in this situation. But again, we continue to offer lots of different options to look at. What is this? They're using this because they feel it's giving them something. What is it giving them? And so to investigate that from that whole person perspective is, I think, my main approach.
Okay.
Yeah.
I'll respond to it too. I think that's a great response, Sue. And Kurt, your question is very appropriate. I wasn't sure if you were asking this question in the context of a group medical visit or in a one-on-one office visit. So I think one thing we need to be mindful about is, in this group visit, we are also trying to provide this trauma-informed approach where we want no one to feel blamed or shamed. So we just need to be mindful of the fact that people have questions, they can, because we also bill for these visits, so we have some interaction with patients, but they have the option to see one of the providers one-on-one in a regular clinic environment. And I think that would be more appropriate place to answer these questions. And I think it really comes down to anything about integrative medicine. I personally think and believe that it's about education. I think there's so much out there, like you said, people have more information than physicians. They come with this information and they get this knowledge from peers, from friends, from family members. So most of the time we are actually, separating wheat from the chaff and say, hey, these are the things which are good for you and why. and these are the things which are harmful for you, and you shouldn't be doing it. And we use the sliding scale evidence of, okay, maybe it does have a placebo effect, but it's not harmful, so we can accept that. And I think that's about building a rapport and relationship with patients. So all of this work happens in more time, but probably will not happen in a group medical visit.
Yeah.
Although some of it does come up in a group medical visit in a very powerful way.
Yeah. I don't know if you can see the chat, but there's a question from Jessica Hultgren. It says, after doing the mapping project, what would you say are the most prominent gaps in accessing integrated pain care? Would it be specialty, geography, culturally specific, and so on?
Excellent question. And it's actually all of it, Jessica. So the southwest corner of the state and the northwest corner of the state have very limited resources for integrative pain care. So it is geography and the diversity of patients, and I would say the income level and economy is going to play a role in all of these issues. This is what we have learned from the mapping study. And we have learned more through these one-on-one interviews that we have conducted. So there is more detailed information, which we are going to publish very soon. And they are about family, they are about income, that's about insurance coverage, it's about access, it's about childcare. Some people can't get to places because they have childcare issues. And then other comorbidities because of which they don't have access to these. Thank you.
Yeah, in the qualitative, not to give away the paper, but like in watercolor broad brushstrokes, what they found in those qualitative interviews for providers to recommend integrative pain care, that the biggest barriers were awareness of it, that they didn't know that it existed, and education around the actual evidence around it. And for patients, the real barrier was access, was being able to get to it. Those were the big barriers that we found. And
if you want to take down your thing, then all the people would be on the slide.
Oh,
Yeah. Go ahead. You were going to say something else.
Oh, I was just going to address having patients get access to integrative modalities, because that kind of leads right off of that. And yes, we do have that problem, although at Hennepin, we're really blessed with having such a vibrant integrative medicine team. So we have acupuncturists, chiropractors, and integrative physical therapists that use a lot of integrative modalities, including yoga and some bodywork modalities as well. However, even within our system where we have all these wonderful providers, access is still an issue because we get booked out really far in advance and then people can't get in to see us. So yes, is the answer. We need more basically system support in order to improve access, we need expanded and better insurance coverage. We need more people trained in these modalities, and we need systems investing in the people that do this work as well, because the access will continue to be a problem.
That's the upstream angle. One of the big upstream angles of getting I call it the upstream policy, to get these things more mainstream and covered,
Is there any plan to not so much taking it on the road, but getting physicians in places at different conferences and teaching them some of the things because let's face it, the average visit when somebody's on long-term opioids for pain is relatively quick. And, how are you doing? Is your pain better? Great. Here's the deal. And they're out the door. I mean, in a way that seems like we should be teaching people, here's the things that might be most impactful. And how can we teach that to physicians if they don't have access to you guys or another program?
Well, I would say come to our echoes because you'll learn a bunch of them. And I wish that Dr. Shafto could be here, because she was an expert at doing, in a short visit time, providing patients with really powerful tools. I know she would teach people just a really simple breathing technique a lot of the time when they would come to see her in the pain clinic, as one little tool, a little gem that they could take away. And I don't know, Dr. Haddo, if you want to talk about your ear points group is another great example of it.
Well, there are a couple of things. There are simple techniques, like the technique that we did at the beginning here, where we just breathe through our heart center and try to find a positive emotion. That I've had people dial down anxiety during an acute visit. And you can just say, hey, here's a tool you can use when you're feeling like you need an extra pain pill because you used extra ones this month. And instead of doing that, try this medicine. Let's have this as a dose and see what that does for you. And, so practice techniques for a quick one-on-one. I use the stop technique as well, where when you're feeling you're ramping up, you go, stop. You stop what you're doing. Just take a moment. What's happening? Assess how you're feeling before you make any decision to proceed. And just that small intervention of moving out of your habitual thing. I feel this pain, or I just talked to my mother-in-law, my neck is hurting so much worse now. I'm going to go take another pain pill or whatever. And instead of doing that, they can take a moment and stop, recognize what's going on. It's called STOP. You can even Google it, STOP.
Yeah.
You can print it off as a one-sheeter and give it to your patient and do it in the clinic with them. So the things you can do in a clinic really easily with a patient are really powerful things.
So Kurt, to your question, such an important question, because you think about the time that we have with patients, like you just talked about.
Right.
I think it's time and education and resources, which are prohibitive for us to do anything additional. The focus is really on this biomedical approach because it is simple, it is easy. We do it all the time. And these things are extra. They take more time. So I think the technique that Dr. Hedda talked about, so great one. I would say the same one for providers, the stop technique, literally just taking a moment to stopping and thinking and just getting into your own space and say, what is bugging me today? Why am I not being effective? Just taking that moment and say, okay, recognize, reset, and going with the patient, and this is really why the training is so important, because as I said, it's all about integrative medicine, education and resources. And some of these are very simple things that we can do. I think we will talk about a lot of this in our integrative pain care echo. So really evidence-based information and techniques, and nice to build that network. I'm sure you can use our NNPM website and maybe find some providers in the community around you, and creating that local consortium of your network where you can refer patients, you can have interactions. Over my practice for years, I have learned so much. It's bidirectional learning. If we don't learn from other providers, we don't know their way of doing things, and we will always be skeptical about why they have done this. So I think it's just communication, patient-provider communication, and provider-to-provider communication, whether they are integrative health providers or conventional providers. I think that's the key to success with patients and quality care.
Mm.
And just one quick thing, and then Sarah has her hand up. Battlefield acupuncture, I don't know if people have heard about this, but battlefield acupuncture is 5 points in each ear that the military devised to get people off the battlefield quickly. And so even non-medically trained people can pop them into the points in the ears, and people can feel an acute relief of pain and be able to walk off the field. Well, we've been doing this in one of my chronic pain groups, and I have had people dial down their morphine use. I have one guy who's told me, my TENS unit is on the shelf. I don't use it anymore. And I hardly ever use I use my gabapentin 3 times a week instead of 3 times a day. So it's some really powerful tools that are out there that training can be done on too. And so we can talk more about that. But Sarah, you've had your hand up patiently for a goodly while.
Yeah, thank you. Can you hear me okay? I'm having some issues with my, oh God. I just want to thank you and commend you. I mean, this is really great work and hit so many highlights of what we have tried to build too around creating yoga programs for people living with chronic pain at Health Partners. And so much of it is lack of awareness about how impactful this work can be for patients. And my biggest take home, I think, is it's really giving them empowerment, because when you're living with chronic pain, it can be very disempowering, and you develop this reliance on the medical system to help you. And so much of these tools, once they're out there, really become tools in the toolbox of how they can apply them and adapt them. And so the work that you guys have done is just amazing. And the fact that you're spreading it throughout the state. And I just want to thank you for all of this.
Thanks for giving us the
Thank you, Sarah.
opportunity to talk about it. We love talking about it, as you can tell.
Yeah, that's, I would like to say is if I'm in the room, yoga's in the room. So yoga was a part of every single appetizer and group visit. Sometimes people might have not known that it was there, but it was there.
Any other questions before we let everybody get back to work? No, some great questions. Great questions. You know, do you ever tell people to get a pet? You know, just calm them down at home.
Actually, one of our I don't like calling them icebreaker questions because they're like connection questions that we'll ask at groups. And my favorite one is when we ask people, what's your favorite animal and why? Because it's amazing how much people connect and light up when they start talking about their favorite animal. People who are like really negative and kind of very skeptical people, you ask them what their favorite animal is and they light up and they start like their whole world.
Shocking.
It's amazing. So in a way, we've not been able to have any actual therapeutic animals in the room, but now you've got me thinking.
Well, I would tell you that don't get a bloodhound if you don't want to have slobber on your leg. These things are really bad. So yeah, something less stressful. So, well, we really appreciate you guys coming on today. This is a fabulous program. And of course, St. Cloud is kind of getting involved with Hennepin as well on this, and it's going to be a wonderful thing. So really, thank you so much for coming. A lot of great information. Please, everybody, feel free to reach out to them if you have questions. And if you guys want to send us something that we can put, on our announcements, we can always put the link as well to your Echo for that, because it's certainly complementary to what we do.
And I put this in the
so
chat, but our final group visit for this round of Heels on Wheels is going to be happening in February, and people can refer into it. So the link, I put it in the chat, but Easing Pain Holistically, Emotions and Chronic Pain will start this February. So if you have a patient, reach out to us and we'll maybe figure out how to get them involved.
Perfect.
Kurt, thank you so much for this opportunity. We are really grateful, and we hope to see some of you with us in our Echoes. And if you want to be part of our WOW grant and a site, please reach out. And thank you for being a site, Kurt.
Do you give people a copy of the PowerPoint, because there's some references in there that people might want to scope out?
Oh yeah.
Yeah, if people
Yes,
want,
we do.
yeah,
Okay.
you can get
Thanks,
it.
Katie. Thanks.
Actually, this is all recorded, so it's on the website as well, so they can go back and look at it.
Okay, fabulous.
Great.
All right. Well, thanks again, everybody, and thanks.
Thank you.
Sue.
Thank you. Thank you, Sue. Thank you,
Thanks.
Sue.
Bye
Bye-bye.
now.